Lovely. We've got people filtering in nice and slowly. So, yes, good morning, everybody. I hope we've all had a lovely extended weekend. I know I certainly did. Today, we're joined by founder and CEO of Synthesis Clinic, the lovely Dr. Nina Fuller-Shavel. Been working with Nina for a little while now. She's a powerhouse in our world, as most of you know. I'm going to stop showering you a flattery. I'm just going to give you the floor and let you do your thing. So with that, everyone, Dr. Nina.
Hello, everyone. So I'm here to talk to you about optimizing recovery and resilience following triple-negative breast cancer treatment. So we are going to just start quickly with affiliation declaration of interest. So as Alex mentioned, I'm the director of Synthesis Clinic. I'm also the co-founder and director of a non-profit called OncoCIC, and we're launching a new cancer support app at the end of June at the IPM Congress. I'm the co-chair of BSIO, and I'm also a CPD education provider and guest lecturer for a number of different universities and institutions. And there's a declaration of interest there for you. So my background is very much in sciences and medicine alongside integrative medicine and functional medicine. I am IFMCP certified. I've also undergone functional medicine health coaching, have degrees in nutrition, integrative medicine, and I'm also a yoga and mindfulness teacher and a traditional Chinese medicine and Western herbalist. So let me just go back to the screen. Here we go, various affiliations and memberships. So what are we going to talk about today? We're going to start with just giving you a little bit of background. I know some of you may not work in breast cancer all the time. So we're going to start by outlining some of the basic concepts around different breast cancer types, with a particular focus on triple-negative breast cancer and how is the treatment paradigm really evolving in this disease. We're going to introduce a bit about integrative oncology and how this approach can be applied and practiced in the UK, and then really dive into the case study, looking at how the chronic fatigue screen, which is a combination of a node test and adrenal stress panel, can be used to guide the personalized support plan following breast cancer treatment. And we'll talk a little bit about how the impact really plays out, apart from seeing changes in test results, really how does it impact not only the objective biomarkers, but also patient-reported outcomes in terms of the quality of life and symptom burden. So let's launch into the breast cancer in TNBC. So I think it's important for us to know that it's incredibly common. The estimated lifetime risk for us in the UK will be 1 in 7 females born after 1960. It is much more treatable than it used to be. So looking at the survival figure, 76% survival for 10 years or more, but it doesn't mean it's not a killer. What's interesting is looking at the preventative side of things as well, which I'll talk to you through some of the risk factors. So when do we know we might be suspicious somebody has breast cancer or needs to check it out with their doctor? Well, we know most of the time it might be a lump or some thickening or some changes in the appearance of either the breast or the nipple in particular. And here are some of the symptoms for you to look out for. And it's really, really important to know, no matter how young someone is, if you're in doubt, we need to check it out. There are a number of campaigns, including Copperfield, that was founded by Chris Halenga, who was told she was too young to have breast cancer, and she definitely did have breast cancer. So please be aware, get all the women and men as well with breast tissue to do regular breast checks, and we need to really make sure we're using all available resources. And the Copperfield website is fantastic because it can also send you monthly reminders to make sure that you do the touch, look and check just to make sure that you're keeping up to date. So let's go back to the risk factors and the preventive side. So this is really where we play a huge role in lifestyle and functional medicine, because as we know, there's significant risk factors for people in terms of obesity and alcohol and some of the other lifestyle factors, including being inactive. So this is where everybody in their clinic should have a significant role in prevention, looking at cutting down alcohol, making sure that people are aware of how much it actually impacts risk, because I think the general population is still very unaware that there is no safe level of alcohol consumption in terms of primary breast cancer risk, and the more you drink, the more it goes up, of course. Weight management is really important, of course, with compassion and kindness, and ideally not always over relying on the whatever the latest fancy medication is out there. The hormone exposures are important to note, and I'm not going to go into the whole HRT and contraceptive pill numbers here, but it is important to be aware of that as a potential risk factor. And being inactive, again, is somewhere we can play a role in terms of lifestyle counselling. And you could imagine if really nearly a quarter of breast cancers are prevented by managing those lifestyle factors, we could have a huge impact on the burden of disease. Here are some of the other risk factors, and again, some of them are modifiable, some of them are not modifiable, but they are certainly something to be aware of, certainly if you're a clinician within that from a medical perspective. So once someone has noticed a change in their breast, or maybe a lump, maybe a change in the nipple, what happens from there? Well, usually they would present to their GP, and they would usually be referred to a one-stop clinic. And the one-stop clinic really means that you can get most of your history examination and some of the diagnostic investigations done in the same clinic. So usually you would have a history, there'd be inspection, palpation by a breast surgeon within the clinic, and then you'd usually have a mammogram plus or minus ultrasound depending on age. And if there is a suspicious lesion that could be biopsied, usually a core biopsy would be taken and sent off for analysis. Breast MRI is an option, but usually is done after all of the other imaging has been completed. What happens after that? Well, really, if someone is diagnosed with breast cancer, after that, really we need to stage and grade their cancer. And the staging is important because the staging really depends on what the size of the primary tumor is, so how big, and that's a T part of the TNM system. So the bigger the lesion, basically the bigger the T number goes, and it goes from T1 to T4. Then are there any lymph nodes? Usually, of course, in breast cancer, we're talking about axillary lymph nodes first. So they're the ones under our armpits. And usually, again, N would be the number that we were looking at, and then N0 means no nodes are involved, and 1, 2, and 3 would be increasing numbers of nodes. And M is an important one because that signifies whether we do or don't have metastatic disease. And usually the staging is done if someone has suspicion of more advanced cancer, really is done by a CT PET scan. Grading is important, so people get confused sometimes between staging and grading if they're not in medicine. So staging is really about how far the cancer has gone, how big is it, and where it's gone to. Grading is really about the tumor behavior. And you can't do grading unless you have a biopsy, and that's really, really important. So once we actually look at the biopsy or a tumor sample, or maybe a sample of removed tissue during a mastectomy or lumpectomy, we can actually have a look at how does the tumor behave. Do the cells still look a little bit like breast cells, or are they now so unrecognizable they're actually really, really aggressive, they don't resemble very much an original breast cell? And usually the grading goes from 1 to 3, with 1 being kind of the slowest growing, the most kind of indolent is how we would describe it, and 3 being the fastest growing. Now, having a grade 3 tumor is not always a bad thing, because they tend to be the ones that are more responsive to things like chemotherapy, because chemotherapy will target the fast dividing cells. Of course, grade 3 tumors divide quickly. So breast cancer subtypes, again, you don't all know all of this unless you work in breast cancer, but this is important for us when we talk about triple negative breast cancer. So there's luminal A and luminal B, and HER2, and they're the ones that are depending on the 3 types of receptors that we might want to look at on the biopsy. So first are the estrogen receptor, that's ER, then progesterone receptor, PR, and the third one is HER2. So these are the different receptors that can be expressed on the breast cancer cells, and depending on the level of expression, we classify them into these different subtypes. And the way we do it and why we do it is really so that we can understand how to treat them the best. So for example, if someone has an estrogen receptor positive tumor, we can use some of the anti-estrogen therapies or endocrine therapies to target that. If someone is just HER2 overexpressing and they don't have estrogen progesterone receptor, we have anti-HER2 therapies. So triple negative is interesting because it's, unsurprisingly, triple negative means negative for all 3 of those receptors. It also tends to be the most aggressive of the breast cancers. So it's usually around 15% of all breast cancer in the UK, and it does disproportionately affect women of colour and also carriers of some of the germline mutations, such as the BRCA mutations, PALB2. As I mentioned, it's usually highly aggressive and has a poorer survival than other types, and the metastases that are really, really widespread throughout the body, from lung, bone, nodes, and brain, are very, very common. And what's important as well is that the risk of relapse and death is significantly higher for triple negative breast cancer during the first 3 years of follow-up. So the 3-year window is really quite important in terms of longer term prognosis. So what are the common treatment options? Well, usually, again, all of these things are shifting all the time. So I tend to have to keep up with quite a lot when I look at it. But usually early triple negative breast cancer is usually meant with surgery plus or minus radiotherapy. The radiotherapy will depend whether we're just going to cut a chunk out, so wide local excision or lumpectomy, or whether there's mastectomy, where there's nodes to irradiate. And there's also chemotherapy. So usually it's something like what we call ECT, epirubicin, cyclophosphamide, followed by a taxane. But there are, of course, other combinations in use as well. If someone with a triple negative breast cancer has been found to have a BRCA mutation, which is one of the mutations in the DNA repair pathways, then usually there's more extensive surgery. There's consideration of bilateral mastectomy and also removal of the ovaries. So BSO is removal of the ovaries and the fallopian tubes bilaterally. And of course, then you'd have to start entering into things like discussions based on age and fertility goals and early menopause, etc. The shifting paradigms, so that's the way that triple negative breast cancer has been treated really for quite some time, but now we're actually emerging into the chemoimmunotherapy paradigm, where we are combining things called immune checkpoint inhibitors such as pembrolizumab with chemotherapy. And that really throws up a new challenge and a new opportunity for us at the same time. The challenge really from the medical perspective is that immune checkpoint inhibitors or ICIs can have quite a lot of immune-related adverse events or IRAs. And they can vary from just feeling a little bit of flu-like to having really significant and serious manifestations that can stay with people for quite some time or require a hospital admission. And that could be things like pneumonitis or colitis or the itis or the inflammatory symptoms, as well as some of the autoimmune disease. And that's really important because that's something that we really need to be monitoring for longer term. And that's type 1 diabetes, autoimmune thyroid disease, and things like Addison's, for example. And they may result in the need for lifelong replacement therapies. And you could imagine that someone went through early triple negative breast cancer treatment and then ended up with an autoimmune disease that is lifelong at that point. That's going to be quite the journey for someone and quite an impact on their quality of life and lifelong medical care. In terms of increased risk of immune-related adverse events, we know that obesity, kidney disease, and of course personal family history of autoimmune disease are all linked to increased risk. What's interesting and what's an opportunity really here is that we know that managing systemic inflammation and managing the gut microbiome in a specific way, including things like very simple interventions like just 20 grams of, or more of fiber a day, can play a crucial role in supporting people's response and improving progression-free survival. In metastatic triple-negative breast cancer, really, chemoimmunotherapy is now standard of care in people who exhibit this particular marker called PD-L1, but there's also further lines of chemotherapy, oral chemotherapy like capecitabine, new options such as sacituzumab govitecan, and many other things that are coming down the line, we hope, that haven't been approved yet. And there might be opportunity to use some of the other targeted agents if we can see different targetable mutations on molecular profiling or liquid biopsies as an example. But again, this is very individual and depends on the country and the approvals within that particular country. So this is just a quick jaunt through, I guess, breast cancer and triple negative breast cancer. What I want you to take out of that really is that breast cancer is incredibly common. 1 in 7 UK women will be diagnosed with it at some point in their life. We have a significant role to play in prevention, looking at all of the preventable risk factors, looking at obesity, looking at alcohol intake, looking at inactivity, for example, and there's some dietary factors as well. So that's really important. And triple negative, what I want you to keep in mind as we go through the case, it tends to be a tumor that is highly aggressive and that has a window of 3 years in particular of having particularly high rates of relapse and death at that time. So trying to protect people early and support the recovery early is really important. So let's talk about integrative oncology as an approach. There are many definitions of integrative oncology, and you'll find one for SIO as well, the Society for Integrative Oncology. But at BSIO, we define it as a rational, person-centered integration of the best of conventional cancer care with evidence-informed nutrition, lifestyle, psycho-emotional well-being support, and complementary medicine. And the goal of integrative oncology is always to support better quality of life, improve patient resilience, minimize the side effects of treatment, and of course, improve clinical outcomes. So that's the aim for us overall. Now, my personal perspective on integrative oncology and integrative medicine in general, and you might hear me talking about it in various places, really, is that it should be a rational integration. It's not about throwing the book at it and seeing what sticks. You need to have a really good rational plan based on your assessment. It does need to be whole person oriented and address multiple needs, from physical, emotional to mental and spiritual needs. And integrative oncology, the clue is in the name, is not alternative. It is supportive and wants to make sure the patient gets the targeted, personalized medication support in cancer treatment, but without over-medicalizing every single symptom. And it is about caring for people, not mindless protocols. And the reason I underline that is because you will see multiple protocols on the internet for triple-negative breast cancer or sarcoma or lung cancer, whatever you want to see. And really, that is not what we do. We really want to make sure we get down to the personal level. It's about personalized intervention that is rational and targeted, not whatever protocol of 20 supplements and 6 off-label drugs people have thrown together. So I'd really encourage you, if you're working in that model, to move away from that model. I know there are some clinics who use exactly the same tests and exactly the same supplements for every patient who comes to see them. And to me, this is not really integrative or personalized oncology. So evidence-based medicine, of course, we need to make sure that whatever we do, it does need to be evidence-based. So we need to combine the best available research evidence, and that might not be perfect. It might actually be quite limited out there, but whatever is the best available research evidence, we need to be aware of it and use it. And we, of course, then need to utilize the clinical expertise and consider patient values. What do they want to get out of this experience? What is important to them, and how do we support them in getting what's important to them? And people who work in this cancer space, in the integrative oncology space, really need to be aware of the overall context in the conventional oncology space, and also emerging advances such as precision oncology. And that's about looking at the tumor, not just saying you have triple negative breast cancer, but really getting down to the detail and saying, okay, well, your tumor might be carrying this specific mutations. And actually, there might be targetable things within that space, or there might be things that affect your prognosis all the way you go through treatment. So this is important because a new drug continually emerging on the market for breast cancer and other indications, and new approvals. So as people who work in the integrative functional space, you really need to be aware of what new medications are coming on board, what side effects they carry, what challenges and opportunities they present for support, and how you're going to actually incorporate them into your practice. So I just want to briefly show you our integrative cancer care team with synthesis. So as you can see, we've got support from medics, and our team is bigger than this because we also have a women's health side, but this is just a cancer support side. So I lead the team. Dr. Helen covers some of our preventive health services and early cancer detection, liquid biopsies. We also have nutritional therapy support, emotional well-being in EFT, as well as nursing from ALGA, physiotherapy, cancer exercise specialism, and of course our administrative and management staff as well. In addition to support from all the staff you see here, we also have an extensive referral partnership network. So we will refer for things like breathwork, health coaching, yoga therapy. We might find local referrals on an ad hoc basis for our patients, such as acupuncture, trauma therapy, and whatever else a person needs depending on our assessment. And of course, charity resource referrals, because it does get very expensive for people to engage with things privately. So we want to make sure they're getting as much as possible on the free side as well. This is a systems approach to cancer that are used in analyzing every single case to come through clinic, and that's what I also teach on my courses for nutrition and medical professionals. And it's very much, as you will see, it's very much derived from the functional medicine thinking, and also functional herbal therapy thinking by Professor Carrie Bone, and really just aims to target down a little bit towards cancer, make it a little bit more specific. So does it matter really? Are we making any difference, or is it just something that's nice to have? And our breast cancer population survey presented at the SIO International Conference in 2021 suggests that women really find it particularly impactful. What was interesting is that only 25% of the women felt that NHS even met their health needs, let alone any broader needs, and that 2/3 of the women, of course, felt that their conventional care teams had no working knowledge of integrative oncology, which makes it very difficult because that means that there is a gap between what oncology teams know and are happy, comfortable talking about and what people want to know. And that's a really important gap that we need to fill. And you can see that 100% of women who engage in the integrative breast cancer service as physician-led has rated our support as very high quality and extremely or very important in the overall care. So it really does make a significant impact. And we are about to analyze our outcomes for the last few years as well. And it's looking very interesting in terms of data. So this is just the background, really. We've covered the breast cancer and triple negative breast cancer as a quick jaunt. And we've covered a little bit about integrative oncology as the approach I use overall, because that helps you place this case study into context. So Kay was a 49-year-old female who presented to the clinic following a locally contained early primary triple negative breast cancer treatment. She's gone through quite a bit, and that was before immunotherapy was really an option. So she had ECT chemotherapy, she had a lumpectomy and radiotherapy, and thankfully by the time they did the lumpectomy she had clear lymph nodes, so she didn't require any further treatment following that. Prior to the diagnosis, she didn't feel unwell, but actually she had a lot of chronic stress, and that impacts things in the healthy habits and self-care, because her father was unwell for 5 years, unfortunately died 2 years before diagnosis. When she came to see me, she really rated her overall health as poor, and she found it really quite hard to recover from that experience. She felt really fatigued in particular. She felt her emotions were all over the place. She had some low-grade digestive tract symptoms. And at the time she was taking 19 supplements, and that was the typical internet list for triple negative breast cancer. She was thankfully on no regular medications, because otherwise there could have been quite a soup to pick through. And she had a reasonable diet, which could have been improved, and was picking up more exercise because she found it really important in the past, and that really dropped off over the time that her father was ill. So what was the initial plan, really? We always start with the basics, of course, the foundations from a lifestyle perspective. So nutrition-wise, we counseled her around an anti-inflammatory, high phytonutrient, polyphenol-rich pescatarian diet. She was pescatarian. And we really emphasize the importance of the overnight fast. We know from observational data, women who fast 13 hours or more overnight, that's associated with a better overall survival, overall clinical outcomes. So 13 hours tends to be the cutoff point that we tend to recommend. She was quite low on protein, despite the exercise. We want to make sure she was having adequate protein balance, and also, of course, PFC balance, so protein, fat, whole food, carbohydrate balanced every meal, to make sure that she was supporting her recovery and energy. She had a good varied regime, so we talked a little bit about the guidelines, the fact that we are recommending, 150 minutes of moderate activity in terms of intensity, or 75 of vigorous on the aerobic front, and 2 resistance training sessions per week, and some flexibility, and then later on in life also balance added, and she was doing a really great job with that. Her sleep was okay. It was a bit wobbly when she would be getting stressed or anxious, but generally her sleep was good. But despite getting adequate amounts of sleep, she was really exhausted. She was already doing mindfulness daily because she found that was really helpful to deal with the stress of the diagnosis and treatment. And then we suggested adding daily breath work and exploring therapy, because the whole experience of going through her father's illness and her own, nearly back to back, was really quite traumatic for her, unsurprisingly. Supplementation was rationalized and reduced, and I'm not going to give you the full list because it was just about trying to rationalize it all down, from 19 down to something that might be actually useful before we get to personalization based on test results. And some of you who work in the space will probably find that, understandably, people come to you with bags and bags of things, a list and list of things, and it can be really difficult to actually rationalize and reduce it down, because they feel like, oh, but what if that's a supplement that's going to reduce my risk of cancer coming back. And we'll talk about the fact that no supplements actually been proven to do it, and it's about supporting the overall person. Really, is making sure we're looking at the biomarkers, but it isn't about one specific supplement really having any significant evidence in this setting. So it's a lot of education, a lot of really people understanding the broader approach rather than a supplement-led approach. So we've done blood via GP and did the chronic fatigue screen via Genova. So the general screen was really normal, inflammatory markers were normal, hematinic, so the B12, folate and iron status were all normal, but there was poor white cell count recovery. And she came to quite some time, it was probably about over 4 months since radiotherapy, so really should have been recovering a little bit quicker. Vitamin D was 99.1, which is normal and above 75 as a cutoff, but perhaps not always that optimal. So chronic fatigue screen, unsurprisingly, shows a hypercortisolism picture and low DHEA and significantly low DHEA to cortisol ratio. So really, we're looking at elevated hypercortisolism at all 4 points. So the OAT was quite interesting. Unsurprisingly, with the low-grade digestive symptoms, there was significant amount of mixed fungal and bacterial dysbiosis and also malabsorption, maldigestion. So that certainly needed work. Unsurprising, when the gut is like this, we often see concomitant elevations in 5-HIAA. That's your serotonin metabolite, because it tends to increase serotonin turnover in the gut. What's interesting here as well, you can also see this sort of picture of pushing things down the kynurenine pathway in terms of the tryptophan pathway going off there, but quinolinic acid, which is more neurotoxic, is not elevated yet. However, I tend to not like seeing kynureninic acid elevations early on, because quite often it will lead later on to quinolinic acid coming up. So it's something that we do need to manage. And usually that is quite gut-driven in my clinical experience anyway. Looking at OAT, she was on a Solga B complex when she came to us, but actually you can see the glutaric acid and isovalerite glycine were both elevated, particularly the glutaric acid. But what's interesting is that always when I look at the vitamin markers, and that might be something that's unique to my practice, but I look at things in context and I want to really see how it relates to the citric acid cycle. So I tend to put the two together and go, okay, well, this tells me maybe glutaric acid may be pointing towards more B2, but actually if you look at it, where we're getting stuck at the metabolic points of the citric acid cycle is actually the steps that much more require B3. So that's something that's important for you when you design, of course, a B-complex supplementation regime, is you need to know what you want to be adjusting if someone's already on baseline supplementation. The toxin detoxification markers were significantly elevated, and you can see the environmental exposures there, and also, an impaired glutathione pathway with elevated pyroglutamic acid and significantly elevated urine lipid peroxides. And that's important for us because, of course, it indicates increased amount of oxidative stress. It's affecting the lipid compartment. And here we might want to look at, number one, what's driving it, but also number two, some of the lipid-soluble antioxidants. So what did we do from there, really? So nutrition, we were continuing to really build out the diet, and she was doing fabulously with that. There was a significant improvement in protein intake and much better PFC balance through the meals. So really we focused down on trying to improve some of the detoxification pathways, looking at particularly brassicas, broccoli sprouts with regard to sulforaphane intake, supporting normal endogenous glutathione pathways. She was drinking quite a bit of green tea with meals, so we talked about how even though green tea has kind of less tannin content than black tea, is probably best taken away from meals in terms of making sure we've got good absorption. We talked about continue with movement and sleep, and she was sleeping much better already. Even though her sleep was, as I said, pretty normal really. So usually she was getting 7 to 8 hours, but we were starting to get improvements in energy finally, even before we started doing personalized work. Psycho-emotional well-being, she really enjoyed adding breath work and felt it was really beneficial. We also diversified the mindfulness practice, because once people start doing the same meditations time in and time out, it tends to drop off. So we looked at maybe adding things by insight timers such as loving kindness meditations, adding yoga nidra, maybe looking at a gratitude practice, and she started looking into therapists. Given the elevated detoxification panel markers, we looked at general environmental exposure advice, and it's important that it is all staged. If you try and tell people to do everything at once and they're already overwhelmed post-cancer treatment, it's just simply not going to work. They're going to drop out. So it is really important that while we want to do everything, we try and stage that. And I find that by the time people are feeling a little bit more motivated, actually it's a good time for them to clean up their environment and start looking at things that are a little bit broader. And I quite often, in terms of environmental exposure, people say, oh my goodness, that's way too much to manage. I normally say start with one room in the house. So start with your kitchen first. Maybe then you go to the bathroom cabinet and just do one room per month, for example, because otherwise it can become like overwhelming and expensive clearing out things that are maybe not so good in terms of environmental toxicants and endocrine disrupting chemicals. But doing that in a manageable way is really important. And then we're going to repeat investigations in 6 months that time. In terms of supplementation, some of the stuff she was already on. So again, I was just trying to continuing to slowly take some of the not so relevant things away and slowly supplement with or substitute with other things, or just take them away, leave them out. So mycotherapy, she was already taking mycomai, which is a maitake extract and lion's mane. Really, we went broader with mycotherapy, looking at myco5 with shaga alternated with PS7, which is a myconutri complex that has things like turkey tail in it, for example, alongside others. She was taking curcumin with enzymes, which is her own supplement, and we converted that to black cumin seed and curcumin combination. And black cumin seed is quite interesting. It's rich in thymoquinone, and that has some gut microbiome modulating effects, as well as some of the antioxidant anti-inflammatory effects. We swapped and cautiously increased B complex dosing, again looking at B3 in particular, and slightly higher B2 dose as well. And we added vitamin C over the winter for immune support and general antioxidant support. The one thing we don't get, of course, with chronic fatigue screen is we don't get 8-OHDG. So we don't get a marker of necessarily water-soluble antioxidant stress at that time. So that makes it difficult to assess that. So that was also a backup from that perspective. She was already on resveratrol, pycnogenol, holy basil, and bergamot from the various supplement lists she acquired, and we were trying to reduce it along the way and sticking to things that were important, but also could manage the things like perimenopausal symptoms for which resveratrol has evidence, and so does pycnogenol to a certain degree. We added biomedical rhodiola complex, and that contains things like rhodiola, Siberian ginseng, and ashwagandha. With regard to adaptogen support, she was on omega-3 with vitamin D, aiming to bump ourselves up a little bit. So I tend to keep most of my people with a cancer diagnosis between 125 and 175 nanomoles per litre in terms of vitamin D levels. Added magnesium glycinate, just given the chronic stress picture and HPA axis deregulation. And added some herbal medicine support, really with regard to supporting the overall picture and fatigue, and also looking at whether we can support some of the white cell count recovery. We also did a temporary condensed 5-hour program, and it was condensed because of time, but also we wanted to see what kind of impact a reasonably generic program would have at that point. She didn't have the budget for stool testing, so we couldn't do that. So we had to go quite broad, and for this I find the in vivo BioClear microbial GI quite useful in this setting where you have a mixed bacterial and fungal overgrowth. And we also gave Schisandra chinensis, which is one of the herbal medicines for both hepatic and adaptogen support. And that was followed by Esboladi as a really good calming probiotic and something that would regulate SIG-A as well. Given her maldigestion, malabsorption markers were elevated, we were looking at bitters and ginger before meals to support that. And for repair, I really like zinc carnosine. I know not everybody can use it necessarily, but zinc carnosine 1 cap twice daily was used short term to look at really repairing the upper GI. She had a few upper GI symptoms, and also the small intestine. And then reducing down to 1 daily for the next couple of months. And then rebalance, looking at the whole parasympathetic system work and the vagus nerve work and the impact of trauma in the system. That was done really throughout. So repeat blood test later on. So here we're looking around about 6 months, just under that. Tumor markers, inflammatory markers, and cardiovascular disease risk markers are normal. And the reason I highlight cardiovascular disease risk is because many of these women have been on cardiotoxic treatments in terms of chemotherapy, But also we know, certainly from a recent biobank study as well as other studies, that cardiovascular disease risk is significantly elevated in survivors of cancer, with breast and blood cancers being particularly impacted. So we do need to assess and address that early. Vitamin D has improved to 131 and white cell count is recovering. And the impact here is less than what we would see with VAE, and that's injectable mistletoe, because that's something that I would use in this particular setting. But the patient wasn't keen on that at the time because of the injection component. We do see a much faster recovery. Usually within 3 months, I see quite reasonable uptick in some of the counts, not with everybody, but with a really good proportion of patients. So looking at the repeat chronic fatigue screen, fatigue rating and perceived stress impact were both significantly improving. As you can see here, we've gone from very high hypercortisolism picture to a much more normal state, but DHEA was still low, about around 0.1 nanomoles per liter. So it's something to note, and that was slow recovery, and that tends to be a slow recovery anyway from the kinetics perspective. Looking at that, this kind of gut program has had a significant impact on bacterial overgrowth, and the malabsorption markers have also all improved, although not quite fully optimal yet. But you can see that she still had some, some yeast and fungal overgrowth markers. DR-ibinitol was significantly elevated. Of course, that was a time when Genova changed over the markers, so we also had to be content with the fact that wasn't directly comparable. So repeat CF screen, you can see with better gut microbiome balance in terms of having a reduced bacterial dysbiosis. You can see the serotonin markers have come down significantly. 5-HIA went down from 19 to 13.2. And you can see also normalization of the push of the serotonin pathway to kynurenine pathway. So all of those markers were all normal, and the catecholamine markers were normal as well, which is good. Lipid peroxide was still elevated, but we saw an improvement in the other OAT markers. I haven't shown you the full panel because the rest of them are normal effectively. But you can see MMA is slightly borderline here still. I'm quite cautious with the amount of B12 I give to patients with a history of cancer, but also I don't really like the huge amounts of methyl B12 that's in most B-complex formulations, so I tend to go cautiously. And at that point, really, we were looking to, we were going to change things up a little bit more and also looked at dietary factors for her. In terms of the mitochondrial metabolites, I think it's really important to see the impact on that. So just through, even though we're not quite optimal yet on the MMA, you can see the significant impact of normalizing the B2, B3, and that's had a significant impact, unsurprisingly, on the TCA metabolites here. And I also, for the first time, show you the fatty acid metabolism, because people sometimes jump on it. They see this reduced fatty acid metabolism and elevated adipic acid, subic acid, and they go, oh, I'm going to give someone acetyl-L-carnitine, or I'll supplement more with X, Y, and Z. And I would probably caution that in my clinical experience, if you actually do a really good job on normalizing other parts of the TCA cycle, the fatty acid metabolism tends to normalize on its own without requiring other intervention. And a small proportion of patients you will then need to do something else, but I tend to do less is more, particularly because it's financially impactful for the patient. So looking at detoxification markers, incorporating things like advice from the IFM detox guide, having regular brassicas and broccoli sprouts in the diet significantly normalized the pathway, and clearly environmental work has also had some impact over the time, and they were all normal at the time. So in terms of the summary of the changes, you can say with HPA axis, we had significant impact on cortisol over 6 months. Although DHEA was reasonably resistant to change, it was still low at 0.1. We had significant amount of dysbiosis markers overall, particularly bacterial dysbiosis markers and also malabsorption, but arabinitol and also glyceric acid, because at that point oxalates were added as well, they were still elevated. Now again, people get quite worried about oxalates for a number of different reasons, and maybe consider low oxalate diets a little bit too readily. But if you have an elevated fungal dysbiosis markers and elevated oxalate markers, the likelihood is, if you do a really good job of treating the fungal dysbiosis, most of your oxalate markers will normalize in line. Okay, it might not happen in a minority of patients, but certainly well worth trying first before putting people on really restrictive diets. There was significantly improved neurotransmitter and B complex markers. There's only mildly elevated 5-HIAA and borderline MMA to really sort. All the mitochondrial functional markers and detoxification markers have normalized, but we do need to tackle persistently high lipid peroxides. And again, it's all about looking at budget and staging. And the way that you'd want to also counsel your patients or clients around it is that you're not going to be able to, very rarely would we ever institute one plan and actually suddenly all of the markers normalize. We need to do it in stages. We can say, okay, well, let's see how much improvement we can get with the first stage of plan, and let's see what we need to mop up. And that's how I tend to counsel people, so they don't expect perfection when they retest. So for elevated fungal markers, what did we do from there? Really, we looked at using Pau-Darco tea as a kind of gut microbiome modulator, using 2 cups daily between meals for 10 days, and then give a break and then repeat. And use continued Aspergillosis probiotics throughout that. We did a smaller retest, not the full thing, but basically showed a reduction in D-arabinitol by 60% and oxalate normalization. And that's what I really tend to see across the board in the vast majority of my patients. Reasonably lower level interventions like that can actually have quite a lot of impact. We added a course of tocotrienols as a fat-soluble antioxidant that might also have a bearing on some of the more cancer pathways, really. And it's important because tocotrienols have a very, very different effect from the cancer perspective than synthetic vitamin E as a DL-alpha tocopherol, for example. And also tocotrienols have a different impact versus tocopherols in general. So we gave it first a D3 in D3 complete, and later on I would tend to convert to higher doses if we don't get that down. And that's really looking at things like 125 milligrams of delta and gamma tocotrienols separately. We also did an adjustment in adaptogens and immune supports because the white cell count has recovered, but reasonably slowly. I wanted to make sure we were continuing to normalize that. So we continue with astragalus and added fucoidan with AHCC. Which we find actually, but that combination is quite interesting because it also impacts things that we don't measure in routine practice, things like NK cell activity. And we swapped to adaptogen complex 6 from Time Health with regard to adaptogen support, and you can see the composition here. And again, just having a broader base, but not using so much separate herbal medicine in terms of cost, because costs were a significant consideration. So outcomes, did we make a difference apart from normalizing the biomarkers, which is all well and good, but we need to see, are we actually seeing clinical impact? And really here we can see that over the 4 months first, MSQ reduced already by 48%, so nearly halved in 4 months, which is a significant impact on someone. And then over the 8 months, we reduced MSQ down to 90, and that's 66% reduction from baseline, with fatigue score significantly reduced, and she had completely normal function, was able to go back to work with no problems over that period of time. Healthcare-related quality of life, we measure by PROMIS. So over the first 4 months, the physical health rating improved from poor to good, very good. And you can see the lines for the mental health and physical health. You can see significant improvement over that time. And over 8 months compared to baseline, the general health rating improved from poor to very good, and mental health rating improved from good to excellent. So you can see both physical and mental health significantly improved over that period of time, which of course makes a difference to daily life. So what is the outlook from here, really? I think it's important to put it into the overall context. And this is why I also talk to you a little bit about that early relapse window. So usually around about 42% of people with TNBC will have a rapid relapse after standard treatment. And that's even with early stages of cancer as well. And risk of distant recurrence really tends to come up to 3 years and then rapidly decline. So having good protection around the first 3 years is really, really important. And thankfully, and I'm not saying that this is due to what we did, but certainly, hopefully we've supported her through making good lifestyle changes and minimizing her risk of recurrence as much as possible in terms of good physical activity and overall well-being. We're now at over 3 years of remission, excellent quality of life overall. She had an unrelated iatrogenic injury because someone decided to do a reasonably unnecessary surgery, which we've managed later on. Overall, it's been a significant impact for her in being able to recover, go back to work, go back to normal life, and also really put the cancer experience into context so it wasn't overshadowing everything that she did. Menopause is important because she was entering perimenopause at the time that I saw her, and then she went fully into menopause later on. So it's about us making sure we're assessing and managing cardiovascular disease risk, because people hit menopause and suddenly the lipids will change, the HbA1c might change. We need to really consider that. We need to consider bone health aspects as well. And can we have a similar impact by using personalized integrative care in metastatic cancer? We could say, okay, well, primary post-treatment recovery, maybe that's all easy, but actually we can have an impact like this in metastatic cancer. And here's a lady who had HER2 positive metastatic breast cancer on treatment with significant mets actually throughout the body. And when we met her, she had an MSQ of 76, and you can see a reduction in 3 months. We were able to reduce it down by 57% in terms of symptom burden. She was then off pain medications, had significantly improved mental well-being, quality of life, and overall performance status, which is really important because how fit and well you are will affect whether you can undergo further treatment. And this was through multidisciplinary input, really using an integrative medicine physician, who was me, nutritional therapy support, and physiotherapy. And this is the sort of outcome, you know, I would say that most clinicians would love to see the metastatic patients putting that down on their form, and that's something that we can achieve with personalized integrative oncology approaches. So as a summary, really, this case illustrates how assessment of the HPA axis and using the OAT testing markers can actually be used to guide and personalize the overall plan. And that's important because they can actually target those kind of low-grade symptoms. Like this lady had low-grade digestive symptoms that she might not have done anything about for quite some time, but there was actually significant dysbiosis underlying that we could tackle. There was a 66% reduction in symptom burden over 8 months and significant improvement in quality of life across both functional domains in terms of physical performance as well as mental health. And just a quick note that dynamic adjustment is, of course, essential. You need to be responsive to any symptoms, improvement in symptoms, and challenges left to tackle, like the challenges I had to tackle at that point were, you know, the DHEA that wasn't really budging, and elevated lipid peroxides in particular. And also you need to be proactive based on upcoming challenges. And that's particularly relevant when you have people who are actually going through active treatment. Now, this was a comparatively simple case because I didn't have any regular medications to contend with, and that is important because really I did not show you any of the drug nutrient herb interaction checks because I didn't have to worry about the drugs in this case. But these are absolutely essential clinical practice and certainly come up in every other case on regular medications through treatment and in living well with metastatic disease.